Now we're beginning Learning Plan 3. So we're thinking about managing care for patients experiencing mood disorders. So Chapter 13 focuses on bipolar and related disorders. So the clinical picture, there are three different types of classifications, main classifications of bipolar. So bipolar used to be called manic depressive disorder. So you might still hear that terminology somewhere because basically that is a pretty accurate description of what bipolar is. They go from episodes of mania to episodes of depression. So, but it is now called bipolar. So bipolar 1 is the most severe form of this disorder and has the highest mortality rate of the three. And you have to have at least one full-blown manic episode and then usually at least one full-blown major depressive episode. So full-blown mania is different from hypomania, and as we look at the symptoms, we'll think about that a little bit more. But anytime you hear in medical terminology hypo, it's usually less than something else. So in this case, it's hypomania would be less than full-blown mania. So bipolar 2, you would have a hypomanic episode and at least one major depressive episode. So the major depressive episode is shared in bipolar 2, but in bipolar 1, people have really severe full-blown mania. Cyclothymic disorder is alternating moods with symptoms of mild to moderate depression for at least 2 years for adults. And they have, and alternating with that mild to moderate depression would be, again, like a lower level of mania. So maybe like a hypomania type episode, and then mild to moderate depression. They never really get into the full-blown, extremely deep parts of depression, but still very uncomfortable. But many people with cyclothymic disorder may not need to be treated in the hospital. So they would be more likely treated as an outpatient with medication, and I would think some therapy also to learn some coping mechanisms to deal with their changing moods. Rapid cycling is also something that is very possible to happen in these types of mood disorders. And so basically people can have very quick mood changes. They can have mood changes that are at least like they can have like 4 mood episodes maybe in a 12-month period, but they can also have mood changes even within a 24-hour period. So if you think about if your mood were to change, even if it's just lower level than full-blown bipolar 1 or bipolar 2, but still to have so much mood fluctuation, you know, on a day-to-day basis or month-to-month, week-to-week, can be still very uncomfortable for people. And I have seen people that have rapid cycling in bipolar 1 and bipolar 2, so their moods can shift very, very quickly. Okay, we have a little case study and an audience response question. Miss A, 53 years old, has just been admitted to your unit with bipolar disorder 1, so bipolar 1 disorder, and is in the manic state. What symptoms might you expect to see? So some of these words you might not even quite understand what they mean yet. Catatonia, well, no, she wouldn't be catatonic because that would mean that she would be completely like nonverbal, not responding, mute, keep eyes closed, whatever. So that's not something typically you see in the manic state. Expression of racing thoughts. Yes, that would absolutely be something that you would see. Low self-esteem and tearfulness. Probably not. If they're in the manic state, they probably have an inflated sense of self-esteem, and they would not necessarily be tearful. Sometimes people do have mood changes where their expression of their mood is quite changeable from minute to minute. They may be crying one minute, laughing the next minute, but usually they are not expressing low self-esteem. Lack of interest in their environment, that sounds more like the depressive part of bipolar. So in the manic state, they're going to have racing thoughts and all kinds of other symptoms that we're going to be getting into in the next couple of slides eventually. So epidemiology, up to about 21% of patients with major depression may actually have undiagnosed bipolar disorder. What makes it hard to diagnose, there are times, honestly, if people are very psychotic with their bipolar disorder, there have been times where schizophrenia and bipolar have been confused and people have not gotten accurate diagnoses because of their delusions or their hallucinations. They have actually been misdiagnosed as having schizophrenia, and therefore the treatment would differ also as far as medications. So, it's really, there's no blood test for mental illness, so it really is difficult to diagnose. You really just have to go by the symptoms that you see, and unfortunately sometimes the symptoms can overlap a little bit from one diagnosis to the other. And we're gonna, we'll be talking about some comorbidities also, which really makes things kind of confusing. So bipolar 1 is more common in males, bipolar 2 more common in females, and cyclothymia usually begins in adolescence or early adulthood. Okay, back to the case study. An assessment interview reveals that Miss A is an adjunct college English professor who has published 2 novels and is working on a 3rd. It was almost inevitable, she says, because I grew up in a family of 5 anxious girls with competitive, ego-driven, professional parents. It was hellish. I found escape in writing stories and putting on plays with my sisters. When I got a scholarship later, I practically ran away to college, where I absolutely lived on coffee, books, and the drama department. Ms. A further describes her childhood, a part of her life she finds particularly troubling. We all had to compete if we wanted attention. Dad played favorites depending on our grades and talents. I was his favorite, but I hated it because it made my mother hate me. How could she compete with her own daughters? Sometimes in high school, I scared myself with how much I just wanted to hurt them both. I decided I would never marry and have kids. So it sounds like she has quite a bit of a dysfunctional family system. So based on her history, which factors can you identify that may have an influence on her condition? So which would be developing a bipolar disorder. So biologic factors, psychological factors, environmental factors, or all of the above. So I'm hoping, based on just even knowing a little bit about the scenario, that you would probably pick all of the above. We don't know for sure about the biological factors, but it sounds like perhaps, her parents, at least her dad, might have had a predisposition or perhaps had some bipolar issues himself. So having that biological predisposition and then the psychological and environmental factors of having that difficult family certainly would influence the development of that condition. So things that we're assessing with people that have bipolar: their mood, absolutely, their behavior, their thought processes and speech patterns, and also their cognitive functioning. So for their mood, we're thinking about, usually if they're in the manic state, we're looking for the mood being very elated, overly happy, more high than normal. So we're not looking at somebody who just happens to be a cheerful, outgoing, very happy, optimistic type personality. This goes way, way above that. And of course, when they're in the depressive end of the bipolar spectrum, then we would be looking for depression, low self-esteem, feeling sad, blue, life isn't worth living, all the things that we're going to talk about for depressive episodes. Behavior sometimes is what gets them into trouble, because their behavior can be very erratic. They can be very challenging as far as their interactions with other people. They can have very behavior that is actually very dangerous. They may be more apt to be taking risks. They may be exhibiting behavior that is risky in terms of even their sexual health. Like somebody might just go out and just pick up people, strange people in a bar, and sleep with them and not really have a second thought about that type of behavior, when ordinarily if they weren't manic they wouldn't be doing things like that. So they're setting themselves up perhaps for infections and perhaps even an unwanted pregnancy. So their behavior, they take risks, they may drive too fast, they drink or use drugs many times during these episodes, more than likely as an effort to reduce their symptoms. I'm hoping that you're thinking that maybe anxiety is kind of coming into play too. And absolutely, during these episodes, their anxiety does tend to be pretty high. Their thought processes and speech patterns, they sometimes have rapid speech. Their thoughts are all over the place. It's very hard to follow them. They talk non-stop, kind of what I'm doing right now. But anyways, their cognitive functioning too then is going to be a bit impaired. They're really not thinking through to the consequences of their behavior. They are really into more, especially in that manic phase, they're really into kind of pleasure seeking. So for speech patterns, we can look at pressured speech. So they're talking so fast, they're almost talking faster than their brain can actually formulate a thought. So the words just come out very, very quickly, and like they can't help the words just tumbling out of their mouth. They might be circumstantial, which means that they're going to be giving a lot more detail than is really necessary. So they're just talking on and on and on and giving many, many details that really aren't necessary to you understanding, what's going on. Tangential, they can start on a topic and they kind of get lost. Their thought kind of goes in a different direction and they never get back to talking about what they originally were talking about. Loose association, so one thing might spark an idea about something else that's not even really related, and then that kind of just keeps continuing. So it's, again, very hard to follow their train of thought when they have loose associations. And then flight of ideas is really a more extreme example of that, where they just keep talking about one thing to the other, to the other, to the other, and there's even no connection. At least with loose associations, you can kind of tell how they got from topic A to topic B, but with flight of ideas, you really can't even tell how they're going from topic to topic. It's just not, things are not related at all. Clang associations, people actually can tell like puns and rhyme like the ends of words. So it's like their speech kind of becomes meaningless because they're more focused on rhyming than they are with actually communicating. And their thought content, they can have grandiose delusions or persecutory delusions. So sometimes they feel like a bit paranoid, like people are out to get them, don't like them, whatever. But the grandiose delusions are so very interesting because they really go along with that inflated sense of self-esteem. So again, they're not going to have low self-esteem in the manic phase. They feel like they are the king of the world. And I had a patient once who was manic, and he wanted everybody to call him King Henry, and he even got a piece of paper and a pencil and wrote a sign, King Henry, put it on the outside of his door. He wanted people to call him that. Of course, we didn't. We staff members did not, because it was not therapeutic. He wore a purple robe, and somebody brought him in, a visitor, I guess, brought him in some purple slippers that had like a golden crown embroidered on them. So he was really kind of, playing it up to the hilt. But he truly believed that he was a king. It wasn't like he was just playing make-believe or, playing a part in acting or something like that. He truly believed that he was a king. So people can believe that they're God, that they're king, that they have communicated with God directly, that they can cure people, they can affect changes in people. And so their thoughts really get very, very delusional, which means that there's just no basis in reality whatsoever. So listening to some of those, it's quite interesting. Sometimes I've heard patients in the hospital on 1K even talk about how, they went to medical school, they're a doctor, they're a lawyer, they're a college professor, and then you kind of look in their history and really none of that is actually accurate. So, but it's their illness that's making them believe those types of things. So a little case study discussion. What are some problems that can be avoided if your manic patient gets proper treatment? Well, one thing we haven't talked about yet is their physical health is really at risk when they're in a manic episode. So not only are they using poor judgment, taking risks, putting themselves or possibly others in danger, but they actually are physically putting themselves at risk. Most of the time, they're not sleeping. That is a huge, huge issue with people that have bipolar. Sometimes they may get an hour or two of sleep a night, and that's it, and very rarely even nap or stop during the day to rest. So what bodily health system, what bodily system do you think, organ system, would be most apt for failure if you continue in a manic episode like this and you're not sleeping? I'm giving you a chance to respond. I'm hoping that you said cardiac, because it definitely is cardiac. Your heart will give out with lack of sleep that goes, if it really goes unchecked and this person who's manic doesn't get help, they can die from lack of sleep, and it is cardiac related. So the other thing is they don't stop to eat very much. So their nutritional status, they could be losing weight and just not having proper nutrition to, for their bodies to function appropriately. Other problems that they get into is substance abuse and alcohol, because sometimes they just are drinking and using drugs as an attempt to self-medicate. They have family and relationship problems. Just think about if a woman in the relationship or the man is manic and they go out and they're having affairs with people, that certainly isn't going to go well with their significant other. So they are putting their relationships at risk, their families. They sometimes spend excessive amounts of money or just make purchases that are just completely, unrealistic, that they really don't have the money for. So I've known people to buy, $50,000 truck, and they couldn't afford a $50,000 truck. It was rather interesting because there was a person once that did that on 1K, and they were wanting the doctor to write an excuse saying that they were manic when they made that purchase so that they wouldn't have to pay for the truck. They wouldn't be responsible for the payment. Well, that was a nice thought, but that didn't go over very well. So, you are responsible for your purchases when you're manic. However, I have seen where they have given, certain companies have given patients leeways as far as returning those items that they purchased when they were in a manic episode, because they really can be, One patient I remember years ago, she was manic, and she must have had her credit card memorized, because we certainly don't allow patients on the unit to keep a credit card with them. So what she did was she made all these phone calls, and she must have had her credit card memorized, and she ordered a new refrigerator, a microwave, a new washer and dryer. She joined a Book of the Month club and ordered like 10 pairs of shoes for herself, 10 pairs for her husband, and then she had all these things delivered to her home. Well, as soon as these things started being delivered to her home, her husband right away called, and he was able to cancel, all those purchases and send everything back, explaining that his wife was in a manic episode at the time. And then actually she had lost her phone privileges for a while on 1K because she was, not able to appropriately use the phone. She was making purchases that were just, completely beyond their ability to pay. So yeah, patients in that manic episode can really get into a lot of trouble. So if they have proper treatment, hopefully we can avoid some of these really difficult behaviors. Self-assessment. So we always have to be aware of how we are reacting to a patient that is manic, because they can be really, really difficult and time-consuming to take care of. They sometimes will display manipulative behaviors. They're always trying to get something that other people can't. They want privileges. They feel that because their self-esteem is so inflated, that sometimes they feel that they deserve to have privileges that other people don't. So very difficult to try to treat everybody fairly on the unit. They can be very demanding. When they want their needs met, they want them met right now, immediately. And that part is very difficult for staff to deal with, because if you're a regular staff on the unit and you have 6, 7, or 8 patients, you can't just drop everything and meet that person's needs. Those needs might not even be a huge priority. They are for the person, obviously, but, when you're prioritizing the care of all these patients, whatever they're asking for right at that moment, that they want you to drop everything and meet their need, it really might not be a priority. So it is very easy to get very, very frustrated and even angry when working with these patients. I had a student once work with somebody who was manic, and after a while of kind of watching how the interactions were going, I had to pull the student aside and say, you don't have to meet every single need. Every time this person asks you to do something, you don't have to do it immediately. And actually, it's probably better, and as a student, of course, you think, the patient wants this, I better go do this now, I better go get this, I better go help them with this. But honestly, it's better if we kind of help them to learn to delay gratification a little bit. So no, you don't have to drop everything and, meet their needs every single second of the day when you're taking care of them. Sometimes it's okay to say, I'll see you in 15 minutes when I do my 15-minute check, and I have to go do some charting right now, or something like that. Or if you had 2 patients, you can say, I have to go and do something else for my other patient right now. I'll get back to you in a half hour, whatever. So giving them time frames and having them delay that gratification can actually be something very helpful to deal with that demanding kind of behavior. They're going to be doing some staff splitting too, and we're going to talk about that again when we think about personality disorders. But sometimes they may resonate with one staff member and really not like another staff member that well, and so they're going to be maybe saying negative things about your peers or negative things about other staff members or about their doctor, and really, we can't feed into that. It's never a good idea to say, oh yeah, you're right, they're just a new nurse, they don't really know what they're doing, or something like that. We don't ever talk about other staff members, or even on a positive way. We don't ever say, oh, but they're a really good nurse, or oh, they're a really good doctor. Usually the best thing, if somebody starts complaining to you about another staff member or about their physician, it's better to say, I think that's, if you have concerns about this person taking care of you, it really would be helpful to talk directly to that person about your concerns. Just so you're acknowledging that they have an issue, but you're not going to get caught in the middle of that and feed into the whole aspect of staff splitting. So staff members' actions are very important, and staff have to meet on a regular basis and deal with the patient's behavior and the staff response so that everybody knows what the approach is and that we can all set limits consistently. There might be a time where the staff might even not want a student involved in somebody's care because they feel like throwing in an extra person might be detrimental, because then the patient might just really feel like, oh good, I've got another person who's new and I can manipulate them and I can be demanding and get things from them that the staff won't give me. So there are times when the staff have asked that a student won't even care for a particular person because of that inability then maybe to be very consistent. So when we're looking for assessment guidelines, we need to think about, are they a danger to themselves or others? Sometimes when people are manic, they can become homicidal towards somebody else. And perhaps those feelings wouldn't be there if they weren't manic. So we definitely need to treat them for their mania and keep assessing, and hopefully those types of thoughts of either self-harm or harming other people are going to resolve. We have to protect them from their uninhibited behaviors. So gambling, spending, sexual activity, all those things that are just uninhibited. Driving, sometimes they just drive too quickly. They don't even realize that they should be following the speed limit. So we do need to protect them. So when they're in a full manic phase, absolutely people need hospitalization. Sometimes people are still hospitalized. I think in your book it might say, yeah, when people are hypomanic, they don't really need hospitalization. But actually, if they're on an upward swing and they have a history of going from hypomania into mania, especially quickly if they rapid cycle, then sometimes it is better to have them in the hospital and get them stabilized to avoid going into that manic episode and to kind of bring their mood back to a euthymic or a normal type of a mood. So the need for hospitalization might also deal with, like, if they have other medical issues going on. So if they are to the point where they're not sleeping, they're not eating and drinking appropriately, they're putting their health at risk, they may need hospitalization for, in order to get stabilized. They might have other coexisting medical conditions that we need to help them with, because perhaps because of their lack of judgment when they're manic, they may not even be taking their medical meds appropriately. They may feel they no longer need their their blood pressure meds, or they may even deny that they have a medical problem. They may not be taking care of their diabetes. Boy, have I seen that one a lot. Not taking their insulin or other meds correctly for anti-diabetic purposes, not following the diet. And of course, think about if you're not eating and sleeping appropriately and you're diabetic, your blood sugar is just going to be all over the place. So we really do have to think about that. And then think about the family's understanding. Does the family understand this illness? If they don't, they really need some teaching, because again, some of the behaviors are so difficult to deal with that the family can end up being angry at the person and blame them and feel that they're responsible for their behavior, when really, if they're in a full-blown manic phase, they truly aren't, because they are so different when they have a stable, normal mood than when they're manic. But we understand that because, if you've taken care of people like this, you see them when they are better, and then they're so different from when they're manic. And even though the family might see them, at different stages, they really have a hard time thinking that the person isn't in control of all of this. So nursing diagnoses might apply. Risk for injury, definitely risk for violence, other directed or self-directed, and certainly ineffective coping. So we identify our outcomes. Again, we always follow that nursing process, and certainly in the acute phase, the biggest goal would be to prevent injury. So sometimes people do injure other people when they're either in the manic or the depressive phase, or they can injure themselves. They may display behavior that is very harmful to themselves, suicidal, or again, just if they were on the outside and they weren't in the hospital, the speeding and just getting into things, getting into areas that they shouldn't be in, and putting themselves in danger. So preventing injury is huge. And of course, preventing the injury from lack of sleep, lack of intake, lack of taking care of their medical problems, all of those things. That's a huge, huge goal that we would have. The next phase, like the continuation phase, when hopefully the mania, depression, the bipolar is kind of more under control, we want to prevent relapse. So we work with that person on staying compliant with their medications. That would be a huge thing to work on, because sometimes if the person themselves with bipolar doesn't understand their own illness, then they really may not understand the need to take their medications on a regular basis, even if they're feeling better, and then to consult with their doctor if they start to feel more depressed or if they start to feel more manic. And usually the thing we teach them is when they first notice that lack of sleep. All of a sudden they're not sleeping as well again. That can be like one of the first symptoms that's going to spiral them into that manic phase. And if they can get that taken care of right away, a little bit of a med adjustment perhaps, or an adjustment in their life, maybe decrease their stress level a little bit, that can help that relapse. We want to prevent them from relapsing and getting right back into that full depression or full mania again. And that maintenance phase, you really want to keep people stable as possible, and we want to limit the severity and the duration of future episodes, because of course if you have the illness, it's not going to just go away. It's a lifelong illness that can be managed, so we really want to limit how many full-blown mania episodes they have or how much full-blown depression they have. So planning, again, medical, stabilizing them, usually in the hospital when they're full-blown manic, maintaining safety, in-hospital nursing care. So we have to think about lots of different things, and definitely their psychological status is very important, but their physical status really in mania is just as important, or even in severe depression too, but here they're just kind of talking about mania. Seclusion, restraint, or ECT may be considered during the acute phase. It depends, because honestly, sometimes we really try not to use those types of interventions unless it's a last resort. It really should be a last resort if we are putting people in a locked room or putting them into restraints. We should really try everything, every other type of intervention before we do that. So decreasing stimulation, again, could be a very important type of intervention. We think about that with anxiety. If somebody's having a panic episode, we want to reduce stimulation, get them to a calm, quiet area. We want to do the same thing with people that have mania. We don't want them going to group and going to all kinds of activities with lots of other people, and we don't want them out in the milieu where lots of people are coming and going and doing things and it's very active. We kind of want to try to keep them a little bit more quiet, not have as many people interact with them, things like that, just to keep things as calm as possible. They may even use the padded room from time to time just to kind of go in and calm down a little bit. So we really need to focus on all those basic needs and keeping them safe. ECT, boy, I haven't really seen that used for somebody in the manic phase, certainly in the depressed phase. But even if somebody has bipolar and they're in the very deep depressed phase, sometimes what I've seen is you give them ECT and then that can flip them into mania like almost instantly. So definitely something for us as nurses to watch for. So we're always managing their medications, and sometimes they don't want to take their meds because some people, when they're acutely manic, they just feel so good. They feel so high and so energetic, and they like the fact that they don't have to sleep very much and they get so much accomplished. They don't want to take their medications because they don't want to come down from that high. They don't want to, and especially if they remember what it's like being depressed, they sure don't want to come all the way down to a depressive type episode. That would just be so uncomfortable for them, so they may not want to take their medications. We might have to decrease their physical activity. Sometimes they are just moving constantly, pacing, moving, busy, doing stuff. And so we don't necessarily want them constantly moving. Again, we want to try to keep them a little bit calmer. We absolutely have to make sure that they're having appropriate food and fluid intake. Think of how many calories they're burning up by their constant motion and their lack of sleep. Sometimes if they're so manic that they can't even sit down to eat a meal, we have to give them food that they can eat on the go. So give them a sandwich that they can hold and eat while they're pacing around. Give them an apple or banana, something they can eat while they're walking, rather than something they have to sit down. They may not be able to sit still long enough to eat a meal. So very important to make sure that they stay adequately hydrated and get enough nutrition. Sleep, boy, that is such a big problem. So, many times we do use medication. We can think about all the other different types of non-pharmacological ways to help people sleep too. Some warm milk, maybe encourage them to take a warm shower, anything they can do to relax, aromatherapy, a little bit of sleep medication, a nice dark quiet environment. So we just really have to also intervene so that their self-care needs are met, because they may not feel the need to go in a shower. They are just not attending to their basic ADLs, brushing their teeth, showering, washing their hair, washing their clothes. I mean, just those real simple basic things. They may just be too busy and too manic to do those things. So during those depressive episodes, those are very, very difficult for the patient to go through, because especially with bipolar 1, their depressive episodes are just really, really severe. They are so depressed. They just can't do anything sometimes. So they may become very suicidal, they may become psychotic with their depression, or even have catatonic signs where they're just, again, not responding. So the medication concerns about bringing on a medication concerns about bringing on a manic phase. Well, you know what? Sometimes when people are they're in that depressed phase, they have bipolar, and sometimes they're treated with an antidepressant. And yes, we do have concerns about sometimes that antidepressant agent bringing them into a full-blown manic phase. So nursing needs to really monitor that very carefully. If we notice that somebody is going from a depressive episode and they're starting to looking manic again, yes, that is absolutely a side effect of some of the medications, and we should be talking to the doctor about that, because they can either change the medication or maybe reduce the dosage. because we want to get them better, but we want them to have more of a stable, normal mood. We don't want to swing them out of that depression right into a manic phase again. So again, hospitalization is warranted for acute mania, bipolar 1 disorder, and usually, honestly, what I've seen is bipolar 2 also get hospitalized in order to prevent them from, getting into a full-blown manic episode, or sometimes that hypomanic state can actually cause them enough difficulty and distress in their life where they're not functioning, so they may need hospitalization also. Yep, lots of different communication challenges and strategies, and we kind of talked about some of the challenges of being demanding and manipulating and things like that. So our communication really has to be very calm, controlled, and we have to, again, we don't have to respond to every single request and meet their every need, drop everything and meet their needs instantly. That's actually not very therapeutic for them. So some strategies might be just minimizing our conversation. And maybe that sounds rude, but you're not going to necessarily do it in a rude way, but actually it's better and more therapeutic to just have very brief, frequent conversations, but very brief. We're not going to sit down and talk with them for an hour because sometimes that might be too much stimulation. So we always have to watch their level of stimulation. If we notice they're starting to get overstimulated and more high and louder and, thoughts coming out faster and faster, we need to intervene to do something about that very quickly. So, pharmacological intervention. So medications, of course, play a very important part too, besides our nursing interactions. So we focus on agitation and mood stabilization. So lithium is one of the kind of the gold standard medication used for treating the manic part, especially of bipolar disorder. It kind of fell out of favor for quite a while, and now it seems to be coming back, and more people are on lithium again. There are other agents that help with the manic episodes, but lithium is kind of considered the gold standard. The problem is lithium has a lot of contraindications, and it has some complications that can happen. So we have to be very careful with lithium and monitor patients. Not all patients can tolerate lithium. They may have side effects, or if they want to have children, they may have to come off of their lithium. You can't become pregnant while you're on lithium. So the indications are for people that have bipolar disorder, and we have to monitor their blood levels pretty significantly. We have to look for that therapeutic blood level, which is about 0.8 to 1.4. Now that's what the book says, but every lab is going to be calibrated a little bit differently. So in some hospitals it might be 0.8 to 1.2, or it might be 0.7 to 1.3. It's going to vary a little bit. So, but it's a very narrow range between therapeutic and toxic. So as you can see from this example here, they're saying the maintenance level is about 0.4 to 1.3. So from 1.3 to 1.4, you might think, just a tenth of a point. If they go to 1.5, no big deal. But actually at 1.5, they can start having symptoms of lithium toxicity, and that we would need to back down off of that. So very important nursing intervention is always check that lithium level before you give lithium. Okay, we actually had that happen in clinical this week, where we didn't have a lithium level, but then when we researched back, we realized that the patient had just started on lithium a couple of days ago and they didn't do a level yet. So we were able to comfortably give that lithium. And then an hour later, I noticed that the doctor had written an order for a lithium level. Well, we had just given that lithium. So I'm hoping that you're thinking ahead as I'm talking and thinking, if they do a lithium level that same day that we gave the lithium at 9 o'clock, and now they're going to do a lithium level at 10 o'clock, that level would be a false high. So I right away, when I noticed that, talked to the nurse and had them reorder the level to be drawn the following day, because otherwise it would have been a false high if we took that level right an hour after we gave that dose. But anyway, so it was good that they were, were checking on that, and that was the appropriate time to be checking it after the patient had been on the lithium a couple of days already. So very narrow range, and if somebody is older, it is very possible for them to become lithium toxic even if they're not at a 1.4. They could be at a 1.0 or a 1.1. And if you're 90 years old and on lithium, it's very possible you can get toxic even if you're not at that 1.4, which is considered the the highest range for that lab value. So always little things to kind of be thinking about. And of course I had experience with that because I did have a 90-year-old on lithium. And she was also on hydrochlorothiazide, which depletes your sodium and your potassium. Well, in order for lithium to be excreted appropriately so that you don't get toxic, the lithium needs to bind with sodium. So if your sodium levels are depleted because you're on hydrochlorothiazide, you're going to become lithium toxic. Your level is going to increase. I'm hoping you're following all this because that really is an important aspect of lithium. So they cannot be on a diuretic that is going to decrease their sodium level when they're on lithium. And I had that experience happen to me where all of a sudden my patient who was 90 and actually quite functional, walked, talked, everything, very independent lady, and she all of a sudden started being ataxic. She couldn't walk. She was slurring her words. Something was going on. And so I was able to put 2 and 2 together and realize that she was becoming lithium toxic. So we do have to monitor our patients for that really very, very carefully. So another little story about lithium that years ago there was a patient who came in and they never checked his, I think it was on the evening shift, and they never checked his lithium level before giving him his lithium. And they kind of did it as an afterthought the next day. But this guy came in and he had classic symptoms of lithium toxicity. His gait was ataxic, so he's walking around kind of stumbling around. He was having diarrhea, like uncontrollable diarrhea, and he was in his 50s, and he was even incontinent of diarrhea. So you would think at that age, like, you'd say, boy, that's not really normal. His speech was slurred, and nobody put it together that that was his lithium. And then when they gave him his lithium that night, and then the next day they checked the level, and it was 2 point something, extremely toxic. He went up to the ICU. So always check your lithium level before you give lithium. Anyways, once people get on, once their level stabilizes, they usually are on a maintenance dose. So again, as nurses, we want to encourage people to keep taking their medications, even if they're feeling better. Contraindications. If people have thyroid issues already, they probably should not be on lithium. If they are pregnant or planning on becoming pregnant, that is absolutely contraindicated. They always do renal and thyroid function studies before starting lithium because it can also impact those two systems. I believe, I'm not seeing this. Oh, yes. Okay, on page 235, lithium is generally contraindicated also if they have cardiovascular disease, brain damage, again, renal and thyroid problems, or myasthenia gravis, which I don't really see very often. It says whenever possible, lithium is not given to women who are pregnant, but honestly, I have never seen lithium given to somebody who's pregnant because I do believe that it is known to cause birth defects. And even people should not, if you're breastfeeding, you should not be using lithium. And in children younger than 12 years of age, it's not going to be used. So on page 234, 235, lots of information about lithium. You're going to be having a discussion question on lithium, so definitely refer to those pages because we really do need to take this medication very seriously and monitor patients carefully. So Ms. A is starting on lithium. Discuss what patient teaching about this medication the nurse should provide before the patient is discharged. So I'm hoping, I'm not going to tell you everything, but, because I really do want you to research this for your discussion question, but people really should need, I guess I'll tell you a few things. People really need to have an adequate level of sodium in their diet. It is not the time to tell them to go on a low salt diet. Because they need that sodium to bind with the lithium, because they have to excrete some of it in order not to become toxic. They need to have an adequate fluid intake. They need to be, of course, again, taking it consistently. They need to have renal and thyroid labs drawn on a consistent basis, have that lithium level drawn on a consistent basis. So actually, on that page 235 in your Varkarolus, that box, that green box that says patient and family teaching, you definitely want to read through that, because there's a lot more in there as far as what to do to help. Should never be given on an empty stomach. There's all kinds of really good things that are in there. So I'm going to let you guys look at that yourself, and then I know that you're going to answer that discussion question really quite thoroughly. We also use anticonvulsant mood stabilizers. So Depakote, Tegretol, Lamictal, those are the very most common ones. Depakote and Tegretol also require monitoring of a serum level. So you might see valproate levels or carbamazepine. So you kind of have to know the both names, the generic and the trade name for these medications, because I do see valproate levels and carbamazepine levels. So you need to know that that's Depakote and Tegretol. I have never seen them draw Lamictal levels. That's one thing I just haven't seen done in the hospital. But if your patient is on the other two meds, then you would also be looking for levels, because people can become toxic if their levels are too high. We also use some antipsychotics sometimes, especially if they're manic and they're very delusional and grandiose. We might be using any of these antipsychotic medications. And I'll get into those probably a little bit more when we talk about the learning plan on schizophrenia. We'll talk a little bit more detail, but just to know that sometimes they do need antipsychotic medications. Yeah, I haven't really seen Thorazine used that much lately, but anyways, loxapine sometimes. I have never seen it inhaled. I've only seen that given orally. So maybe some first or second generation antipsychotics are used. Again, ECT, I haven't really seen it used very often when people are bipolar, because you have to be really careful. Even if they're in the deep depressive phase, sometimes I have witnessed at least a couple of times that they go right from depression right into full-blown mania as a result of ECT. It just changes their brain chemistry just very, very quickly. So again, teamwork and safety, we all have to be on the same page when we're working with patients that are bipolar. Make sure our interventions are consistent and that we really understand their need to not be overstimulated. Seclusion, again, we don't really use those types of interventions unless absolutely necessary. Support groups are great support groups for bipolar, and we always should be encouraging patients to either attend support groups, either in person or even online. Support groups can be very helpful. Bipolar, depression, anxiety, so many of our medical or our mental health illnesses are not seen as medical illnesses. They're seen as weaknesses, character flaws, and they're not visible. It's not like you broke a leg and you can see the cast on your leg and, everybody's all rallying around you with support. Or even sometimes cancer can change your appearance so very drastically. But people that have these types of mental illnesses can look on the outside completely, absolutely fine. So it is very hard for people to understand and give support to somebody with these illnesses because they don't look sick. They look fine. So why aren't they behaving fine? That's kind of the mindset. So I do think that support group aspect is very helpful. And then, of course, health teaching and health promotion, how to live a healthy lifestyle, how to try to avoid stress, and try to avoid the manic or the depressive episodes. So again, advanced practice interventions are pretty much the same for most of our, most of the learning plans. We're just going to kind of look at, yes, if you're an advanced practice nurse, you're going to be doing different types of therapies. So when we have the evaluation, we want to see that our outcome criteria are met, that we're going to always reassess the care plan and make sure that if there are changes that need to be made, that they are communicated to everybody, and so that we do those revisions if indicated. So So on page 238 in your Varcarolas, they talk about quality improvement, and then there's this Standards for Bipolar Excellence project. No, you don't have to go through and memorize it all, but there is a nice paragraph on this quality improvement project, and they talk about assessing risk of suicide, assessing for substance abuse, monitoring their weight, monitoring for extrapyramidal symptoms if they're on antipsychotic meds, monitoring those lithium levels, and just kind of all the types of things that you're looking for as far as hoping that they have a better, change of functioning, because quality improvement, again, is one of those CUSIN competencies, and nurses can be very valuable in collecting data, and just by our using the nursing process when we're working with patients can help to improve their care and improve their lives. So audience response question, which anticonvulsant medication might be prescribed for a patient with bipolar? So that would be Depakote, Klonopin, Zyprexa, or Lithibid. So I'm hoping that you picked Depakote, although honestly it's a little bit of a trick question because clonazepam or Klonopin, sometimes the benzodiazepines can actually be used for, they can be used for seizures, so they kind of could be classified as an anticonvulsant, but technically clonazepam is a benzodiazepine anti-anxiety agent. Zyprexa would be an antipsychotic, and then lithium, of course, is very specific as a mood stabilizer. But we do use Depakote quite frequently. Okay, I think I'm going to start a new recording. We'll start here when I record next on depressive disorders.